introduce Babak Mokhlesi. You're a professor in medicine and director of the sleep program at the University of Chicago. He is a Chicago person. He was at Rush. He was at University of Illinois, and then he came to University of Chicago. I know we've sent a couple fellows into the Chicago area, and they know who you are and have been pleased to step into some of the roles that you had previously done. So I asked him here to talk a bit about hypoventilation, but really it's his, as they say in the movies, it's his paramount. So it's if you could you can share your screen. I think you can start it off, and thank you very much for being with us today.
Thank you so much for having me. And so, yeah, as Kingman said, what I'm hoping to cover this hour is some of the experiences I've built over the years in relation to obesity hypoventilation syndrome.
No, hold on, Grandpa.
So these are some of the objectives we'll cover today, as you can see on the slide. And I always like to, start with a good example of a patient with obesity hypoventilation syndrome. People might ask, how come this poor soul didn't undergo a split night polysomnogram, because it looks so obvious that it's abnormal. Obviously, for those who are not familiar with this is the sleep stages. Black represents REM sleep. This is the oximetry. And as you can see, that's 90% red. I actually put some thought into this, the color blue for cyanotic. That's the 70% line that I put. You can see this is significant hypoxemia. And in this case, we also have transcutaneous CO2 measurements. You can see that it's significantly elevated throughout the night. And this is a patient who is a research subject. That's why there was no split night. Otherwise, normally in most, sleep labs, this patient would have been initiated on some form of CAP therapy. And what I like to point out most of the time is that most patients with obstructive sleep apnea, garden variety, severe obstructive sleep apnea, don't look like this. In terms of, sure, they can have significant oxygen desaturations with the sawtooth pattern on the oximetry, but they usually don't go this low as this patient is going in terms of their oxygenation. And, in terms of transcutaneous CO2, many places don't routinely measure them, us included, but most patients with obstructive sleep apnea don't get this level of hypercapnia during sleep. In fact, the great majority don't. And this is a 2-minute window just showing that these patients have, significant hypoxemic burden in terms of oxygen saturation nadir, time below 90%. But I think the problem with time below 90% doesn't do it justice. Sometimes in these patients, you have to talk about time below 80%, time below 70%. And I think that's why, this new metric of OSA severity, looking at hypoxemic burden, is going to be an interesting one to explore as we move forward as a field. The other thing I want to point out to you in this research subject is, the blood pressure. These boxes, red boxes, represent systolic and diastolic blood pressure. These are being measured non-invasively with the device, similar to, like the PhenoPress device, beat-to-beat blood pressure monitoring. And you can see that every time that a patient experiences an arousal with a sympathetic surge, you can see that the blood pressure rise is quite dramatic. I mean, look at this. This is almost like 50 millimeters of mercury from 119 to 194, from 100 systolic to 162. Clearly, during the apnea, the blood pressure can go down, but with the sympathetic surge, it goes up. And I always tell people, with ambulatory blood pressure monitoring, which measures blood pressure, say, every 15 to 30 minutes, you're not able to capture these significant rises in blood pressure, which last only, 10, 12 seconds, for example. Now, what are the downstream consequences of these brief periods of severe hypertension? I don't think we know for sure, but whether these are some of the mechanisms by which patients develop stroke, in the middle of a night or sudden cardiac death, I wouldn't be surprised. You know, it certainly could contribute. So I think there are two camps in terms of how to define obesity hypoventilation. One camp includes sleep disorder breathing within the definition, and some don't. I think I'm on the side. I'll be honest with you. I've published both ways, and I think it's somewhat of semantics because all of them have sleep disorder breathing. Most of them have OSA. Some of them just have sleep hypoventilation, meaning whatever hypoventilation they have during the day just gets worse at night. But at the end of the day, these are individuals who have evidence of awake hypercapnia, and the PaCO2 is above 45 millimeters of mercury. It's important to consider where the patient lives, because if they live at high altitude, your CO2 levels may have to be adjusted accordingly. And, you know, it's obviously a diagnosis of exclusion, but we can't be dogmatic either. I mean, some of these patients may have some evidence of restrictive thoracic defect because of their body habitus. They may have mild obstructive airways disease also because of obesity, perhaps. So, you know, my point of view is that you want to make sure they don't have severe COPD or severe parenchymal lung disease and those kind of things, or severe hypothyroidism. And in terms of its prevalence, I think the prevalence, nobody knows whether the prevalence of OHS is going up or not, but one thing that we do know is the prevalence of severe obesity is going up. So most recent data from the CDC suggests that the prevalence of obesity, both in adults and children, has plateaued, which is good news. But that's not to say that once you're obese, you cannot get more obese. So as you can see in this graph, orange, if you look at 2010 and to 2016, which would have been here, there's not that much change. But you can see that BMIs above 40 and above 50 is actually going up. And in fact, the latest that I think the CDC published was in 2016. So hopefully soon they'll publish another analysis. But in the latest, they said close to 8% of US adults have severe obesity, defined as BMI above 40. And in the African-American population is higher, as you can see in the slide here. Now, again, this is a busy slide, so I'll summarize it for you. We don't know what's the prevalence of OSA in the community. We can estimate it, but at least in obese patients referred for suspicion of OSA to sleep programs, you can see that from a variety of countries here, the rough estimate is around 17%. Some places more, some places less. The places that have more is because they have more obesity in their patient population, and vice versa. So if you are in a program in a city where you have a lot of obese patients coming to your program with severe obesity, chances are at least 10% of your patients do have evidence of hypoventilation, but many times, we don't know that, we don't capture it. Now, there's nothing unique about the United States having a higher prevalence, as I try to illustrate in this slide, whether you're in the UK or France or Italy. As the BMI goes up, the prevalence of OHS goes up. The problem is that we in the United States have higher levels of obesity than other countries. So a while back, I tried to kind of estimate what could be the prevalence in the population using, back of an envelope calculation here. So this is a US census from 2010 in terms of US population. Percent of adults will dwindle it down to 245 million. If you believe the CDC data, 7.7% of the population has BMI above 40. That'll take you to 19 million people. If you say conservatively of these individuals who have a BMI above 40, half of them have AHI above 5, you could argue more, but let's say half to be conservative. That's 9.4 million. So now you have 9.4 million who are severely obese and have AHI above 5. Then you say, the slide that I showed you, in that population, 10 to 20% people have reported have evidence of hypercapnia during the daytime. So let's take the 10%, the lower side. That takes you to 940,000 people in the US, or 1 out of 263 adults. So now to put that in perspective, here it is. obviously diabetes, asthma, OSA, COPD are much more prevalent. And this OSA prevalence that I put here is more clinically significant OSA as opposed to just AHI above 5. But you can see that compared to narcolepsy, IPF, ALS, it's probably much more common. Again, we don't know for sure, but it's probably more common. And it's interesting because when you look at federal dollars spent on research in this area compared to narcolepsy or even pharmaceutical, IPF or ALS, there's big differences there. So I think there's room for improvement in terms of research in this area, funding for research. So again, we estimate 0.6% of the general population in the US. Europeans have published that it's probably lower, because they have less obesity. Again, if you look at obese patients with obstructive sleep apnea in sleep programs, 10 to 20%, depending on which study you look at. If you look at people with very severe obesity, BMI above 50, referred to the sleep programs, some studies have reported even higher prevalence. And I'll talk about this study by Paul Merrick when he was in West Virginia, where 8% of patients admitted to their ICUs had met criteria for OHS essentially. So years ago, I kind of summarized a bunch of the literature at that time, and even more recent data hasn't really changed this. But in essence, these are individuals who present not very early in their life. I mean, most of them are in the 5th, 6th decade of life. And the women are very well represented in OHS. It's not like OSA. Most studies that I've seen, at least 40–50% of the population are women. Women tend to be older than men with OHS and tend to be more obese, which is not that dissimilar from what you see in OSA literature. As you can see, the body mass index tends to be on the high side. Now, except for studies from Japan and other Asian countries where with lower BMIs, as we all know, they can get hypertension, diabetes, obstructive sleep apnea, and OHS. So, but again, in people of European ancestry or even African Americans, it's very hard to get OHS with a BMI below 40. It's not impossible, but it's uncommon. And you can see this is again in ambulatory settings, in the outpatient setting. Obviously, they present with a balanced pH. The CO2s tend to be in the low 50s, but there's a range, obviously. There's concomitant hypoxemia. And interestingly, you don't see a lot of secondary erythrocytosis in these individuals. You would think that, because of chronic hypoxemia, they would have, very high hemoglobins. Rarely you see that. And I think part of it could be, and I don't know the answer to that, but I think part of it could be because they're also quite inflamed. And whether that chronic inflammatory state because of obesity leads to some condition of anemia of chronic disease, which counterbalances the excess production of erythropoietin due to hypoxemia, is possible. Now, the other thing to point out is these individuals are quite dyspneic. Medical Research Council dyspnea scale 3 and 4. 4 is essentially you get short of breath with anything, and 3 is with activities of daily living. So 69% of people in the studies have been shown to have significant dyspnea. And in contrast to obstructive sleep apnea, even severe obstructive sleep apnea, where almost half of the patients may not have subjective daytime sleepiness based on the Epworth, here is it rare for patients not to be sleepy, at least in the OHS literature. And then when you look at their polysomnography data, the great majority have severe OSA with significant hypoxemia. And spirometrically, you can see that mild restrictive defect is not uncommon. Sometimes it can get quite moderate as well. But again, a lot of that has to do with body habitus and not parenchymal lung disease. So these 2 studies that I'm showing here, one is from Spain and the one is from Paul Merrick's group. The other one is from the Denver group from years ago. So in this study from Spain, they looked at patients getting admitted to the ICUs with acute and chronic hypercapnic respiratory failure. And what they noticed is that 65% of them had prior ICU admissions, and only 9% of them were on therapy at home. So clearly an opportunity for better, treatment and diagnoses. In this group from Denver, again, this is 16 years ago, what they found was that in patients hospitalized under wards, not in the ICU, but just on medicine wards, who end up having a BMI above 35, a good proportion of them had evidence of hypoventilation. And when the research team informed the clinical team that, heads up, your patient has likely OHS, only 13% were discharged on some kind of therapy. So I think there's room for improvement here for all of us taking care of these patients. And the other study that I was going to share with you is this one by Paul Merrick that I alluded to a little bit earlier. So they looked at ICU patients and they surmised that around 8% of these individuals in their ICUs met criteria for hypoventilation due to obesity. What was sad is that 75% of these patients were mislabeled as COPD or asthma, when by history, at least, there was nothing to suggest that. 86% were treated for heart failure. Many times these patients get over-diuresed because it looks like they have edema in their lower extremity, and they may have lower extremity edema, but it may not be heart failure. And you can see how they can get into this vicious cycle of excessive diuresis, CO2, bicarb retention due to contraction metabolic alkalosis, and hypoventilation getting worse. And many of them were labeled as COPD exacerbation or heart failure. So again, that's another challenge that we face, trying to correctly diagnose these individuals. So how do these individuals present? So again, as an intensivist, I'm sad to say that a lot of it is what we see here on this panel. People come to the ED, get labeled as COPD exacerbation, they get slapped on non-invasive ventilation, and they get admitted to the ICU. And then, then we do a very expensive test called history and physical. And then we realize that the individual has been a lifetime non-smoker. And on physical exam, there's no evidence of prolonged exhalation or expiratory wheeze, nothing to suggest they have obstructive airways disease. And finally, a pulmonologist or intensivist says, look at the BMI, look at the history. There's nothing to suggest that this is COPD. And then they get labeled correctly. The other way we diagnose these individuals is when they get, for suspicion of OSA, they get evaluated in the clinic, or they get referred directly to the sleep lab. And you get a sleep study that looks like the one I showed at the beginning of the talk, with profound hypoxemia, both intermittent and sustained hypoxemia. And there might be other clues that this patient has hypoventilation on top of OSA. So when to suspect it? Again, as the BMI goes higher, I think the suspicion should go higher. Serum bicarb, and I'll show you some of the data that we published on this, could be helpful, but you have to be cautious because polymedication, polypharmacy, some medications can make the bicarb go up. Importantly, loop diuretics, as we talked about earlier. Hypoxemia, I always tell people a patient with, plain OSA should not have daytime hypoxemia while they're resting. And if they do, one should pursue that as to why is it. With that said, many patients can have hypoventilation based on blood gas analysis, but not have hypoxemia. They may not reach that steep portion of the oxyhemoglobin dissociation curve to the point that they may have, pulse ox of 91, 92%. So I think if the pulse oximetry is low, it's helpful, but if it's normal, doesn't rule it out. Again, if patients have evidence of restrictive defect on spirometry and they're severely obese, it just puts them at increased risk of they probably have some degree of hypoventilation as well. And again, persistent hypoxemia and significant hypoxemia on polysomnography just kind of makes you get a little suspicious. When I see that pattern, I kind of open our electronic medical record to see if there's any old bicarbs in the system, any old blood gases and those kind of things, see if I can kind of come up with more clues. But this is what I was alluding to a while back. We published this looking at people referred to us who were obese and had OSA. And what we noticed is that if the serum bicarb was below 27, the chance of hypoventilation true hypoventilation on blood gas was extremely low. So in other words, if the bicarb is normal, then the chance of OHS is almost none. If the bicarb is elevated, the chance of OHS is a coin toss. So a high bicarb doesn't rule it in, a low bicarb rules it out, so to speak. And this is what we also found when we put together the American Thoracic Society clinical practice guidelines for OHS last year. This was what, in kind of combining all the literature, what we noticed, and it's kind of a busy slide, but I'll summarize it for you. At the end of the day, if the bicarb is above 27, we recommend a blood gas. If it's below 27, we feel that there's a good chance that you won't miss that many people. And even if you miss people, they probably have very mild hypercapnia, perhaps PCO2s of 46, 47, 48, those kind of things. Now, from the pathophysiological standpoint, I think there's several things to think about here. One is, obviously the balance for developing respiratory failure is always a balance between respiratory load and drive and strength, like we talked about in the intensive care unit. But what's unique about patients with OHS is because of their body mass, they have more CO2 production. Now, most obese people, the adipose tissue is metabolically active. Anything that's metabolically active consumes oxygen and by definition produces CO2. Obese patients produce more CO2. The majority of obese patients do not have CO2 retention because as they increase their CO2 production, they also compensate by increasing their ventilation. So the question is why in a small subgroup of patients that doesn't happen? And I don't think we really know the answer. But other things to think about, again, so they have increased CO2 production, but they also have a blunted drive. Centrally speaking, their chemoreceptors are not as responsive to hypoxia and hypercapnia when people have tested them. On top of that, they have increased resistive loads, not only from the thoracic perspective, chest wall perspective, because of all the adipose tissue, but also upper airway obstruction, which can also increase respiratory load for them. And obviously, when this balance tips over, so these patients almost live on the edge, if you will. So if you are at a pH of 7.38, a PCO2 of 53, and you develop a mild viral infection with a little bit of a fever, you can see how they can easily tip over and develop acute on chronic hypercapnic respiratory failure. Many of these patients who get admitted to the hospitals with acute on chronic hypercapnic respiratory failure, the inciting event was probably an infection, or if they have concomitant heart failure, a little bit of fluid overload and those kind of things. Now, as I said earlier, if you look at pathophysiologically, what are the mechanisms? Again, CO2 production, increased CO2 production is definitely an issue. And this is where people have come up with this concept of leptin resistance. And by this, for example, adipose tissue produces leptin. Leptin is a hormone that is anorexogenic, but it can also stimulate at the hypothalamic level ventilation. What's interesting is that despite having excess leptin in the circulation, these individuals do not augment their ventilation accordingly based on the elevated CO2 production because of obesity. So that's where people have come up with the concept of leptin resistance. And a very elegant study by Seva Polotsky's group from Hopkins, published a couple of years ago in the Blue Journal, really gave nice clues about this. What his group did is they had a mouse model of hypoventilation. And when they injected leptin intraperitoneally, which would be systemic, there was no impact in terms of changes in ventilation and improvement in CO2. But when they gave it intranasally, where you can directly go into the CNS, they showed that there was evidence of improvement in ventilation, suggesting that perhaps one of the problems is that leptin is there, but it just doesn't cross the blood-brain, the CSF. It doesn't get into the CSF. And that's kind of one of the working hypotheses here. And now there's some reasonable evidence in animal models that might be the case. So who knows, maybe in the future, one of the treatment interventions would be intranasal leptin for these individuals. Mary Ip and I wrote the editorial on that paper in the Blue Journal, and we kind of went over that possibility. But again, that's years from now. The other thing that's interesting about these individuals is this concept that was proposed by David Rappaport's group in New York, where they talked about acute hypercapnia during sleep. And if you have, if you're predisposed to retaining some bicarb at night and not eliminating the bicarb appropriately the next day, you can see how the next day you may wake up with a slightly higher bicarb level, and you might be slightly alkalotic or alkalemic. And then most people would eliminate that by peeing the bicarb, the slight amount of bicarb that was retained overnight. But in those individuals who don't, you can see how that could blunt the ventilatory response. Again, this is a mathematical model that they came up with. We don't have any evidence, at least in human experiments, that actually happens. But again, is an interesting concept. And again, obstructive sleep apnea is a major player here. And the reason I say this is because I think there are two camps here. One is the patients who have severe obstructive sleep apnea, and obstructive sleep apnea is a major contributor to CO2 retention during the daytime. I think all of us can conceptually understand why severe OSA will make you retain CO2 during the night. The question is, why does it happen during the day? Why does it carry over? And this is why this model proposed by David's group is an interesting model that has to do with elimination of bicarb by the kidney, which is blunted. But the point I'm trying to make is that many studies have shown that if you treat obstructive sleep apnea with CPAP during sleep, BMI being the same, the patient's CO2 starts getting better. So in those individuals, one could argue that obstructive sleep apnea was in the causal pathway of that individual developing CO2 retention, because just by virtue of treating that at night, with no change in their body habitus, hypercapnia resolves. Then there's a subgroup of patients that you treat them with CPAP or even with non-invasive ventilation during sleep, and the hypercapnia doesn't go away or doesn't go away completely. And the hypothesis is that in that group, perhaps obstructive sleep apnea is not the main driver of the CO2 retention, and maybe in those individuals, it's just other issues that are contributing to it. So now at the end of the day, the question is, well, why should we treat it? Well, I think as the slide here summarizes, is because they have a lot of morbidity and mortality, and I think treatment impacts that. For example, this was a study from Denver years ago that I talked about earlier, where the treating team was informed that your patient may have OHS, but the vast majority of patients were discharged without therapy. None of these patients died in the hospital, but you can see that few months after hospital discharge, those who had evidence of hypoventilation, this Kaplan-Meier survival curve starts separating at 2-3 months. Again, during the hospital, they had more admissions to the ICU and more intubations, but nobody died in the hospital. And here again, this is a study we just talked about, hospital deaths, 0. There was another study of a small number of patients, 0% died. This is a study that I showed you earlier in Spain, where they had 173 patients admitted to the ICU with acute and chronic hypercapnic respiratory failure due to OHS. 6% died in the hospital. And the study by Paul Merrick, which retrospectively looked at their data from their ICUs, 15% died in the hospital. So it's a significant burden. Again, this is just hospital death. If you look at longer term mortality, again, this is the same study from Denver. Nobody died in the hospital, but at a year and a half, 23% were dead. The study by Carrillo, you can see 6% died in the hospital, right? 18% died at 1 year. I'll go back one slide. The study by Merrick, 15% died in the hospital, but at 3 years, it was 31%. And again, we think that most of these patients were untreated. Again, we don't don't have good data, hard data, but we think that's the case. In these studies that I pointed out here, you can see that these were ambulatory patients. There was good adherence to therapy, and the period of follow is much longer. And you can see that mortality rates are lower. Again, don't compare 24% to 23%. This is 7 years of follow-up. This is 1.5 years. So be cognizant of the duration of follow-up here. Now, the other thing is that these patients may just have been sicker because they had required a hospitalization for whatever reason. That could be part of the the driver of higher mortality. So we can't really we have to be cautious how we make inferences from this data. So treatment options, I've listed here a bunch of options that we'll go over some of them. So if we think about positive airway pressure therapy, again, here you have a variety of options. And in terms of effects of PAP therapy, here this slide doesn't do it justice, but just to summarize, years ago, Banerjee and Amanda Piper's group in Australia published that if you look at patients with OHS who undergo CPAP titration, 43% failed CPAP titration, meaning they define CPAP titration as persistent hypoxemia on the ideal pressure. The ideal pressure being the pressure that resolves apneas and hypopneas and so forth. I wrote the editorial on this years ago, and I said, well, that means 57% did well. So, it depends if you're half full, half empty person, glass half full, half empty. Then they did a small RCT, the same group, comparing 18 patients on CPAP to 18 patients with bilevel PAP or BiPAP without a backup rate in the spontaneous mode. And in this study, they excluded people who failed CPAP titration, meaning they had persistent hypoxemia and CPAP. So these are people who all underwent CPAP titration. If the CPAP titration was successful, then they would get randomized to CPAP or BiPAP. And then they would go BiPAP titration if they were randomized to BiPAP. And again, there was no major differences in the outcomes at 3 months. And most recently, they published this paper, the same group, Mark Howard was the lead, but Amanda was also part of this group, where they randomized 30 to CPAP and 27 to bilevel, now with a backup rate in spontaneous time mode. And again, similar improvements at 3 months. In this study, they did not exclude people who were CPAP failures. It was essentially all comers. Looking at AVAPs, and this is a volume targeted pressure support mode versus bilevel with a backup rate. Paddy Murphy from the UK published this study where they randomized 50 people to these two different modes, 25 in each group roughly. And again, no major differences in outcome. And you can see that the bilevel titration was quite aggressive and not that different from AVAPs. So the average delivered inspiratory pressure was 23, the EPAP was 10 or 9, leak was the same, percentage of triggered breaths were the same, adherence was not that dissimilar, and the changes in CO2 at 3 months was not that dissimilar either. And most recently, the French group published a study where they compared AVAPs, but now with the auto EPAP feature, kind of like your auto CPAP. So this study, the EPAP was fixed. Here, the EPAP could go up and down based on the analysis of the upper airway flow curves. And compared to bilevel ST, again, when there's no major differences between them, meaning a pretty good bilevel titration, there was no significant difference in changes in CO2 and other things. So there's nothing magical about volume targeted pressure support as long as you have a very aggressive and comparable bilevel PAP titration. The problem is that many times in sleep labs, the sleep techs may not be comfortable doing this level of aggressive bilevel titration. And in that setting, one could argue maybe AVAPs would be a better choice, AVAPs or IVAPs. Now, this brings us to the Pickwick study, in which there's 2 studies here, those who have severe OSA with OHS and those who don't. And you can see the majority of people have severe OSA. That's around 70% of the population. So 70% of patients with OHS have OSA with an AHI above 30. And in this group, at 2 months, there were 3 arms. And then after 2 months, this group that was randomized to lifestyle modification was re-randomized. And then these groups were followed for a minimum of 3 years. So the last patient had to have 3 years of follow-up, essentially. That's why some patients have more. The first patients had more. In the other group, there was no CPAP because the idea was that if they don't have severe OSA, why give them CPAP? So they were randomized to non-invasive ventilation versus lifestyle and followed at 2 months and longer. And this is what we published recently. This is a long-term data. So you can see that the median follow-up was 5 years. And so average CPAP in those randomized to CPAP, which is around 100 something people, was 10, 11. CPAP usage was not that different compared to NIV usage. The NIV group, this is again volume targeted pressure support. You can see the average pressures were 20/8, so around 12 or so of pressure support with a backup rate average of 14 breaths per minute. The primary outcome was hospital days, and there was no significant difference between the two groups. Other outcomes that we explored was incident cardiovascular events, 15% for CPAP, 17% for NIV. Mortality rate didn't reach significance either, 15% for CPAP. This is 11% for NIV. And here's the Kaplan-Meier survival curve. As you can see, no significant difference between CPAP and NIV in patients with OHS who have severe OSA. In terms of causes of death, you can see that cardiovascular causes of death are the predominant cause in both groups. And here's longitudinal changes in PCO2 at baseline and over time between the two groups. Again, both groups improved significantly, but no significant difference within the groups. This is the improvement in oxygen. As your ventilation gets better, one expects the CO2 to get better and the O2 to get better as well. You can see that both improve significantly, but no difference between CPAP and NIV. And again, NIV here is volume targeted pressure support. This slide this is one of my favorites, dyspnea, because patients may not care about whether their CO2 goes from 52 to 44. I mean, from the patient perspective, that's irrelevant. What they care about is, do I feel better? And dyspnea is relevant. And you can see that both groups had a significant drop in their dyspnea, but there was no significant difference between CPAP and NIV, which is the good news, I suppose. Need for daytime supplemental oxygen. That's another thing that patients care about. Do I have to walk around with a concentrator or with an oxygen tank? So you can see that in the CPAP group, 27% at baseline required oxygen during the daytime. And it went down to 13% at the end of 3 years. 22% in the NIV group went down to 11%. So both groups had a significant decline in need for oxygen, but there was no difference between them. And here's change in Epworth Sleepiness Scale. Many of you may be aware about this concept of minimally clinically important difference, MCID. And for example, there's some literature to suggest 2 to 3 point change in the Epworth Sleepiness Scale is considered minimally clinically important difference. So here you can see that on average, the Epworth went from 11-12 to like 5-6. This is a big drop in Epworth Sleepiness Scale. Now, years ago, we published that one of the main predictors of whether your CO2 changes or not is how much you use PAP therapy. And in this study, we categorized patients into PAP use, CPAP or NIV for that matter, 4.5 hours or less than 4.5 hours a day on average. And you can see the changes in CO2 in the arterial blood or oxygen in arterial blood was significantly more if you used it, more adherently compared to those who didn't use it. So the same thing was found here. Now that was in terms of CO2, but in terms of survival, we looked at two groups. Those who use NIV or CPAP more than 4 hours a day, your typical Medicare definition, versus people who use it for less than 4 hours a day. Again, this is in the Pickwick study. And you can see that for those who use NIV or CPAP adherently, there was no difference in outcomes in terms of survival. But those who used it less, both of them did poorly compared to this group. Now, recently with my fellows last year, we were asked to write a paper on PAP adherence in OHS, and there hasn't been really any studies looking at ways to improve adherence in patients with OHS. But what I did with my fellows was to look at the literature here. So let me explain what this graph shows. This is looking at CPAP adherence in clinical trials, RCTs, where patients were randomized to usual care, patients with OSA, or telemedicine to improve adherence. And you can see that in the clinical trials where patients were randomized to telemedicine interventions, on average, CPAP adherence improved by an hour. And then in clinical trials where behavioral interventions were done to improve CPAP adherence, again, this is a conglomerate of a bunch of studies. You can see that CPAP adherence improved by almost an hour and a half. Now, these are the studies of OHS where patients were either randomized to CPAP or NIV, but there were no interventions. These studies were not designed to improve adherence. Regardless, even when there was no interventions to improve adherence, you can see that the adherence is significantly higher than even these two groups, which are the best for OSA. And my argument has been that these patients are probably more symptomatic and they derive more benefit from their therapy and they feel better with their therapy, and that's why they use it more compared to OSA patients. Again, that's my inference from the data. Now, the other thing that I want to share with you, which may create some controversy, is earlier I talked about a couple of studies where they excluded patients with CPAP titration failure due to persistent hypoxemia on titration studies. So I want to share with you 3 patients here that were enrolled in one of our research studies. Each patient underwent full night of PSG, and in a week they had to undergo a full night of titration, and they were randomized to CPAP, AVAPs, or BiPAP. And then after 6 weeks of home therapy, they had to come for another PSG while they were sleeping in the sleep lab under set machine setting at home. So 3 PSGs. Each line is 1 individual. So the green guy, the red guy, the blue guy, 3 patients. And what I want to share with you, so these are people who were randomized to CPAP, who had significant hypoxemia on the ideal CPAP pressure. When I say ideal CPAP pressure, 2 of these patients are on CPAP of 20, and the AHIs were close to 0, but they had significant hypoxemia. One of them was on CPAP between 17 to 20, and there was a substantial amount of time, like 3 hours, 4 hours on these settings. And what I'm showing you is that on the reasonable CPAP pressure, this individual had 70% of the time with oxygen saturation below 90. This individual had 60% of the time with oxygen saturation below 90. This person had around 40-something% with T90. And if you look time below 80%, 2 individuals had substantial amount of time with oxygen saturation below 80%. Now, once they were randomized to CPAP, we could not label them, we had to give them CPAP essentially. So these patients went home on CPAP with no oxygen, just CPAP. And in 6 weeks, they were highly adherent to CPAP therapy. They were using it around 6 hours a night. And in 6 weeks, they came back to the sleep lab. And they slept under home CPAP settings, which was 2 of them were CPAP of 20. The other one was CPAP of 17. And you can see that the hypoxemia that was present during the titration was all gone. The point I'm trying to make here is that CPAP titration failure, defined as persistent hypoxemia during CPAP titration, is not necessarily equivalent to CPAP treatment failure. And in fact, in the Pickwick trial, the clinical trial where people were randomized to CPAP versus NIV, if the patient was randomized to CPAP and they had a horrendous titration, tough luck. You got randomized to CPAP, you stay on CPAP. And you can see that you could say, well, this is only 6 weeks of data. What happens down the road? Well, the Pickwick trial has data up to 3-4 years, showing that there was no difference between CPAP and NIV in the subgroup of patients who have severe OSA as well. So other lessons that we learned from the Pickwick trials, well, CPAP is cheaper. That's a no-brainer. And the other thing that was, I think, very interesting was looking at pulmonary hypertension. So again, for a clinical trial where you're going to do assessments of right heart function and estimation of pulmonary artery pressures periodically every few months or once a year, it's hard to do right heart cath. It's hard to convince people to undergo multiple right heart caths. But so with all the limitations of echocardiograms, again, the definition of pulmonary hypertension here is systolic pulmonary artery pressure above 40 by echo. And you can see that the average drop was around 4 or 5 millimeters of mercury in the systolic pulmonary artery pressure. However, if you look at the subgroup that had pulmonary hypertension to start with, and that was 50% of the population. So of the 200 and something patients that we had, 100 of them had evidence of pulmonary artery pressure above 40 based on echo. And these are these two groups here. One arm is CPAP, the other one is NIV. And you can see that over time, the drop in PA pressures was around 8 to 10 millimeters of mercury. This is a significant drop at 1 year, 2 years, 3 years. The group that did not have pulmonary hypertension to start with, which is the other half of the population, of course, if you don't have it, there's no room for improvement. So that's a no-brainer. But if you combine these two, the average drop is around 4 or 5 millimeters of mercury, as I said here. But in the group that has pulmonary hypertension, the drop was more dramatic, as you can see. So I think this is interesting data. You know, I wish it was right heart cath, but it's hard to do 4 right heart caths in people over 4 years in a population of 200 people, if you will. So far I've been saying that it sounds like there's no role for NIV. You know, and the question comes up, well, when should we use NIV? So in the clinical practice guidelines, we talk about this. And as you can see listed here, if the patient doesn't have severe OSA, the suggestion is maybe CPAP is not the best treatment choice. Obviously, if they come decompensated, they have to go on NIV. You know, and one of the challenges is that, you know, we lump everybody together. Let me give you an example. If I have a patient who has a BMI of 42 and has a CO2 during the daytime of 49, sure, they meet criteria for OHS. But I think most of us would agree that that's not the same as another patient who may have BMI of 70 and have a baseline CO2 in steady state with a balanced pH of 59. The point here is that there's probably a higher chance that the person with BMI of 70 and a higher CO2 at baseline would respond poorly to CPAP than the person who has a BMI of 42. Again, I don't have any data to support that, but I think it's reasonable to think that way. And that's one of the things that we try to express in the clinical practice guidelines, because we didn't want to create a dogma that everybody has to be on CPAP, because I don't think that's the entire truth. But here's some of the data we try to collect from observational data for the clinical practice guidelines. What happens to patients who get admitted to the hospital? They get better, they survive hospitalization, it's now time for discharge. How do we discharge them and have them come to the clinic? Do we discharge them to the sleep lab? Do we discharge them on some form of therapy? And we don't know, because there hasn't been any clinical trial that has addressed that question. So you're at the mercy of observational bias data, which is what we're showing here. So when we collected this data from investigators who had published on this, so what we did is I went to all 10, there were 10 studies in the literature in which a subgroup of patients or all patients were enrolled while during hospitalization. So I reached out to the investigators and I told them, can you share with me these data points on your patients? For each individual patient, give me these data points. And I sent them an Excel spreadsheet. And luckily, all of them were collaborative, except for one, which was a Denver study from 2004. They were collaborative. I mean, Cliff Zwillig was the senior author of that paper. But, you know, when I reached out to Cliff, he has retired, and he shared with me a picture of him fishing in one of the Colorado rivers, inviting me to go fishing with him. He said, I don't have the data anymore. It was all on paper at the VA, and that data is gone essentially. So out of the 10 studies, we had 9 studies that we could collect data. And you can see that this is a total of around 1,200 patients or less. The great majority were discharged on some form of PAP therapy. 92% of them were NIV. A small percentage, like 10%, were discharged on no PAP. And you can see the mortality rates at 3 months is substantially different between the two groups. And at 6 months, it's still different between the two groups. Again, this is a biased sample because we don't know why these people were discharged without therapy. So it's hard to make a lot of inferences from this. And that's why we were very cautious how we worded this in the clinical practice guidelines, that because we didn't want to shut doors for future research. We didn't want people to take this and say, this is a new dogma. Everybody has to be discharged on some form of therapy. We need good research to ascertain whether this is actually true or not. And this is one of the ideas behind our next project, which patients get randomized to lifestyle modification versus lifestyle modification with automatic NIV and follow up at 3 months. This is from hospital discharge. We think that it will be easy to convince IRBs to approve this kind of study because the idea is that we will guarantee that the patient will be seen in the clinic in 3 months and go on therapy in 3 months. To be honest with you, at least at my institution, many times these people get discharged and nobody refers them to the sleep clinic to start with. So we want to make sure that the non-treatment arm is not inferior to, current standards, I suppose. So lastly, I'll share this study with you that was just published. This is a study in which they looked at how safe it is to switch people from NIV to CPAP. And they had 42 patients with stable OHS, and which they had improved, their CO2s had improved to normal after several months of therapy. And 37 of them were able to be switched to CPAP. And of these, 30 maintained eucapnia over time. That means 70% of 42 people. 7 of these individuals who were placed on CPAP eventually developed mild hypercapnia, and they were switched back to non-invasive ventilation. Interestingly, I thought this is interesting. Of the people who were switched, of these 37 people who were switched to CPAP, the majority of them preferred CPAP over bi-level with the backup rate. So that's interesting. Now, in the last few minutes, I'll talk about other therapies. I'll tell you that oxygen as a single therapy has no role here. And in some patients, depending on how much oxygen you give them, sometimes they can have worsening of their CO2 retention, so be mindful of that. Bariatric surgery, you would think there'll be a ton of literature on this, but unfortunately, there's not much. One of the few good studies that are out there is by Harvey Sugarman from the mid-80s, and as I summarize here, there was improvement after Roux-en-Y surgery. The average weight loss was around 50 kilograms or 110 pounds. That led to significant improvement in gas exchange and in lung volumes. In the ATS clinical practice guideline, based on the very limited literature, we recommended that patients should be talked about and referred for bariatric surgery because for them to really get resolution of OHS, they probably need to lose 25–30% of their actual body weight. And I think the balance is between, because I think these patients with OHS have slightly higher risk from bariatric surgery than the average patient. But I would say that the risk is not, very, very high. Medroxyprogesterone, I've used it a couple of times. It's a concern because this is one of the good studies out there from several decades ago, as you can see. And this was in the era where they were not doing routinely polysomnography on these patients. So we don't know how many of these 10 men with OHS actually had OSA. But what you can see here is that when they gave them medroxyprogesterone at a high dose 3 times a day for several months, despite no change in weight, there was significant improvement in, in their hypercapnia. And I'll show you in a second. 2 developed impotence, but in those days, they wouldn't talk about erectile dysfunction. So I don't know how many developed erectile dysfunction. But as a proof of concept, this was quite interesting. You can see that the CO2s went down significantly, remained normal. Oxygen levels went up significantly and remained normal. And then as a proof of concept, when they stopped it for 1 month, in 7 of these 10 individuals, you can see that the PCO2 went up again. When they restarted it, it went down again. Same thing with the oxygen, got worse and got better again. So I think it works, but the question is, what do you do? I mean, I think the concern is that level of medroxyprogesterone most people are not going to be interested in taking it, men and women, because it can lead to breakthrough bleeding in these women, could increase risk of thromboembolism. So I don't think it's really a good option. Uh, in terms of acetazolamide, again, we don't have any robust studies in that using this or a clinical trial using it. But again, I think it can work in these patients. But again, not as a sole therapy, maybe as an adjunct to PAP therapy. Tracheostomy, again, you would think there'll be a lot of studies on tracheostomy, but there isn't. This is a retrospective study from Hopkins looking at 13 patients who had, most of them had evidence of hypoventilation, and you can see that PCO2s after surgery went down. This line is 45 millimeters of mercury. But it's important to recognize that some patients, despite getting trached, hypoventilation persists. If they were of the phenotype that they were more pure hypoventilators, like the classic Pickwickian, in which OSA is not a major contributor, you can see how tracheing them is not going to augment ventilation. And these patients end up getting trached and they need to be hooked up to a Trilogy device or an Astral device, which they could have used non-invasively potentially. So trach could help hypoventilation if OSA is a major driver of hypoventilation. So to conclude, again, hopefully I've convinced you that OHS is more prevalent than what you think. Most of these patients have severe obesity and significant OSA. In fact, 70% of these patients have severe OSA as well. It's frequently unrecognized and undertreated, many times mislabeled erroneously as COPD exacerbation or heart failure exacerbation. And then I think it's important to recognize that treatment should not just focus on PAP therapy, because as I showed you earlier, the great majority of mortality in the Pickwick clinical trial was cardiovascular events. So similar to the OSA literature, treatment of severe OSA, and in this case, treatment of OHS, may not be sufficient for secondary prevention of, or perhaps even primary prevention of cardiovascular disease. In that sense, these patients may need more, may need to be engaged in weight loss interventions, in increasing physical activity and healthier lifestyles, as opposed to simply, PAP therapy at night. With that said, I think there's a lot of opportunity for research to explore the role of bariatric surgery in these patients. So with that, I want to acknowledge people who funded some of our studies, the ATS for funding the clinical practice guidelines, and my partner in crime, Fernando Massa in Spain, and the Spanish Sleep Network. So I'm happy to take any questions. Thank you.